Once your patient is ready for intubation, the RVT will place the end of the laryngoscope blade at the base of the tongue. They will then lift the laryngoscope handle, which will depress the blade on the tongue and open the airway so you can visualize the arytenoid cartilages. From there, the RVT can decide which of the 3 endotracheal tubes they wish to use for intubation. In this image, you can see the airway, which is where you will insert the endotracheal tube, and the arytenoid cartilages on either side. These will typically move in and out as the patient is breathing. They are sensitive and must have local anesthetic sprayed on them to prevent laryngospasm. The RVT will spray feline patients with lidocaine spray to prevent laryngospasm. You will wait 15 to 30 seconds for it to take full effect. Next, the tip of the lubricated endotracheal tube is gently inserted in between the arytenoids and into the airway space. Notice how the RVT gently advances the endotracheal tube. There should not be any resistance felt. It should feel like a knife going into soft butter. If resistance is felt, your tube may be too large and you will have to try the next size down. Next, the endotracheal tube is secured by a snug tie around the endotracheal tube. Then, tying it behind the patient's base of skull and the ears. Depending on the procedure or the species that you're working with, you may also secure the endotracheal tube to the maxilla or the mandible. Next, the anesthetist is going to leave the patient in sternal recumbency while connecting the circuit and oxygen to the patient. You do not want to change the patient's body position until after the cuff is inflated, as moving them can increase the chances of reflux and aspiration pneumonia. The ET tube must next be checked for a good seal, meaning there are no leaks around the tube, to protect the patient's airway, prevent waste gas anesthetic exposure, and to help maintain the depth of anesthesia. It is imperative that the anesthetist performs this task in a safe manner. It is not safe to assume that there is a leak and instill a volume of air into the cuff without first, number 1, checking if there is a leak, and 2, listening for the leak while instilling the air simultaneously. It is also important to note that the inhalant gas should not be turned on until a proper cuff seal has been established. We will demonstrate this in the next video. You can see that the RVT has about 1 ml of air in their syringe. They securely connect the air syringe to the pilot balloon, and then they completely close the pop-off valve. Next, the RVT will give a breath hold to 20 centimeters of water. Note how the RVT is watching the pressure manometer while giving the breath hold to ensure they do not exceed 20 centimeters of water. If a leak is present, you will hear air escaping around the outside of the tube. It is easier to detect this with your ear close to the patient's head, but still watching your manometer. This RVT heard a leak. Next, they reopen the pop-off valve to prevent excess pressure from building in the circuit. They then completely close the pop-off valve again and give another breath hold to 20 centimeters of water, and slowly instill air into the cuff. The important point to note for this procedure is that you only instill air while simultaneously administering a breath hold and hearing the leak at the same time. You will know there is no more leak when you do not hear the gases escaping around the tube. It can take multiple breath holds to achieve this. It is important to always remember to open the pop-off valve once you are done the cuff inflation. If it is left closed and undetected, it can be fatal to your patient. Once a sealed cuff has been established, the inhalant gas can be turned on to ensure your patient stays asleep. You can also change their body position at this time if necessary. It is important that the anesthetist confirms the endotracheal tube is in the trachea. As per your lecture notes, there are many ways to confirm this. One method that should always be performed is bilateral lung auscultation. If you hear lung sounds bilaterally, this can tell you that your tube is in the main stem bronchus and not down one side of the chest. You will also watch for observing the chest wall rising with each administered breath that you give. This will also provide a baseline for lung sounds post-induction in case anything changes with your patient later in the anesthetic.